Welcome, everyone, and thank you for joining us today. My name is Melanie McGackin, and I'm representing the Rutgers Community Living Education Project team, better known as CLEP. I will be your host for today's presentation. Today's webinar will be featuring Dr. Wendy Ada from the Rowan-Virtua Regional Integrated Special Needs Center. Today's presentation, Dr. Ada will address the challenges that individuals with intellectual and developmental disabilities may face in accessing routine medical care. She'll examine how factors such as anxiety, fear, and past medical trauma can impact healthcare appointments. And more importantly, she'll discuss practical and compassionate strategies to overcome these barriers. Whether you're a healthcare provider, a caregiver, or advocate, you'll walk away with tools to help create more supportive, adaptable, and inclusive healthcare experiences for the people that you love and support. Before we begin, just a few notes to help you get through today's session effectively. For sound quality purposes, all attendees will be muted during today's presentation. The webinar is being recorded and a link will be sent by the end of the week. So if you registered for this session, you're going to receive that recording automatically. If not, you can, feel free to share with others through the YouTube channel. We welcome you to introduce yourself using the chat and let us know where you're joining from. We are here to learn from each other, so we encourage you to share your topic, specific resources, or suggestions. Please feel free to do so using the chat feature of your Zoom control panel. If you joined us before, you know that we love to keep our sessions interactive. So if you have a topic-specific question during the presentation, please drop it in the Q&A box and we'll make sure to address it as long as time allows at the end of today's presentation. So we're looking forward to a meaningful and solution-focused conversation. So with no further delay, I will hand the virtual mic over to Dr. Ada. Dr. Ada, welcome.
Yeah, thanks a lot, Melanie. Thanks for having me here today. As Melanie indicated, my name's Dr. Wendy Ada. I'm a clinical psychologist and an associate professor at the medical school at Rowan School of Osteopathic Medicine. And I work in a specialized care practice called the RISN Center, which Melanie kind of gave the really long name for it. It's the Rowan-Virtua Regional Integrated Special Needs Center. So we are a primary care practice at our core for individuals with special healthcare needs as they age out of the pediatric system of care. So oftentimes individuals have a really nice opportunity for healthcare when they're children within their pediatric practice or at tertiary centers, and they have all of their specialists that are related to the care that they need. But as they age out of school and they age out of pediatric care, they need somebody to kind of be a catcher. And that's what we do at RISN Center. We're the catchers who help to become your new medical home. But part of what we are is also an interdisciplinary practice where we have integrated behavioral health. So I'm the co-director of RISN and I'm in charge of behavioral health. And a lot of the work that we do is really helping to address disparities in healthcare access for our patients with different abilities. We are very health focused in our practice. If you got to meet my colleagues last week, Dr. Jennifer LeCompte and Andrea Iannizelli, you heard about us focusing on wellness, on, kind of trying to understand the root cause of either medical problems or behavioral difficulties rather than that kind of traditional medical model of only addressing symptoms. So what today I'm going to talk about is why access to routine medical procedures is so important, especially for our loved ones with different abilities. What are the barriers to routine medical procedures? And then we're going to learn about the impact of anxiety, fear, and previous trauma as barriers to healthcare access and creating ways of decreasing fear and anxiety and creating a personalized plan. And I'll take you through really two different types of programs that we have here at the RISN Center, although we kind of focus on all healthcare access. The two that kind of come to the forefront most frequently for me are addressing needle phobia or fear of needles and lab draws, and what we call PAP Camp. And I'll tell you a little bit about that in helping individuals get access to their reproductive health care exam. So, what are health disparities? Health disparities are preventable health inequities or avoidable differences in healthcare between different groups of people. They're experienced by vulnerable populations because of their poor access. They have significant disparities in terms of longevity of life, chronic health conditions, just because of belonging to a particular group that is marginalized. And people with intellectual disabilities remain one of the most underserved groups. Actually, the National Institute of Health only identified people with disabilities as being a marginalized group in September of 2023. So, although we've known that our loved ones and individuals haven't been getting the same access to routine procedures or medical care as neurotypical population, this was just identified as a marginalized population in 2023. So why is that important? Well, if a group is identified as a marginalized population, that allows funding to be put towards trying to understand what the healthcare disparities are and how we can accommodate for those. But our patients have a 4 times higher mortality rate than their neurotypical peers, higher rates of chronic illness and hospitalizations, and they have difficulty accessing care that leads to higher rates of really preventable medical problems. Our goal at the RISN Center is for inclusive health. And what that means is not that everybody needs the same access to health. And that's really what equality is, right? Everybody gets the same amount of what they need in order to make everything fair. The reality is equality doesn't necessarily get everyone access. It's only equity. Really understanding what the individual needs and developing a plan to surround that individual so that they can access healthcare in the way that makes sense for them. So our goal is to address the barriers, build sustainable, inclusive policies, and hopefully, what that does is to result in better healthcare outcomes, less chronic disease, less morbidity and mortality for our individuals. I'm going to talk to you a little bit about barriers to healthcare. Very quickly, just going to go over, kind of the typical barriers to healthcare, but we're going to talk very specifically about emotional and behavioral barriers to healthcare. So looking at barriers, first are architectural barriers. There are some individuals who still have trouble just getting in the door. Even though with ADA accommodations, all practices should have wheelchair accessibility, the ability to be able to see patients within their office, and we find that still we have some barriers there. Medical equipment can be an additional barrier. Just something like being able to get a basic demographic like somebody's weight, if they don't have a wheelchair scale, is something that makes it difficult for our individuals. Being able to move from a wheelchair or to be able to pivot onto an examination table can be a problem for individuals with disabilities. So at the RISN Center, we try to address all of those medical equipment disparities by having a lift within our rooms, having wheelchair scales, and having accessible beds that move up and down as well. Communication can be a barrier. And that really means like the ability for individuals with disabilities to be able to communicate with their healthcare providers in a way that, and the healthcare providers communicating to them in a way that they can understand using language that they understand, but also being willing to take extra time, let the individual have time to be able to explain things. And sometimes our individuals need a little bit more time, being able to utilize assistive communication, making sure that that assistive communication is brought to the medical appointments, and being able to talk to the patient first, giving them their voice, and then utilizing their support people as support people. It also means having an opportunity to talk to your doctor alone, so that you have some privacy when you see your physician. Economic barriers are, multiple, especially in relation to healthcare insurance and access especially with Medicaid. And when we're looking at possibility of Medicaid funding going down or decreasing, is really concerning to us that our individuals are still going to have good access. But New Jersey is actually the third highest state in the United States of healthcare providers who do not accept Medicaid. So this is a real barrier because you can't go to just whoever you would like to go to because there are so few individuals in terms of physicians or other healthcare providers who will take Medicaid insurance. Social policy, kind of kicking everybody out of pediatric care at the age of 21. Attitudinal barriers. So there was a research study done just a couple of years ago that found that 84% of US physicians believe that people with disabilities have a poorer quality of life than people without disabilities. And then, within the current political climate, just recently, the comments that have been made about the poor quality of life of individuals with autism. That's an attitudinal barrier that gets in the way of treating individuals as human, as people within their own right and worthy of getting the healthcare access that they need. And also, making sure that we're not making assumptions about the quality of their life based upon their disability. And then inadequate provider knowledge. We often do not train medical providers. And for me, as a psychological provider, we often don't train psychologists on how to work with people with different abilities, how to adapt psychotherapy or any other types of therapy for people who might need to receive it in a different way. And so that really becomes a barrier to healthcare as well. And then I'm going to talk to you about the emotional and behavioral barriers that get in the way of basic healthcare. I did want to put real quickly in the chat a couple of things. It's not going to let me copy that. So I might have to do it at the end. I have a couple of forms that, one of the things that is really important for us is that we can help individuals have as much agency within their healthcare access that they can be able to have independence in their healthcare access as much as they can. We actually have a program to help individuals kind of learn how to make their own doctor's appointments or how to order refills on their medications. So I have a couple of forms that are reproducible that individuals can fill out before they come to their medical appointments to help them organize their thoughts, to help them come up with questions they want to be able to ask their doctor. So I'll provide them a little bit later as we're going along. So basic healthcare can be scary. And guess what? You know what? Healthcare is scary for most of us. Healthcare is scary for me sometimes. But when I have a question about what's going to happen during a medical procedure, I have the opportunity to phone a friend. I can ask, some of our providers here. I can go on Google and get some information about what's going to happen during a healthcare exam. But many of our individuals don't have that opportunity to do that. And then when you kind of combine that with kind of fears in general of medical procedures, there are so many things that go on in a medical procedure that are frightening to people. It's unfamiliar stimuli, it's loud noises, separation from people that you that are your support people that care about you, being in the dark, and injections. All of those things are developmentally appropriate for individuals with an intellectual disability. And also, people with intellectual disabilities actually identify a higher number of fears just in general, fears of the dark, fears of weather, fears of thunder, than individuals their own age. So when you combine all of those things together, healthcare is going to be very scary. And there are a lot of different healthcare procedures that are scary, but the ones that tend to have the most limited access include dental procedures, blood tests, and needles. So those are going to be the ones we're going to focus not as much on dental, but on blood tests, needles. And then we're going to talk a little bit about PAP camp as well. So the literature shows that compliance problems during during medical procedures is relatively common for individuals with ID. About a third of patients actually have some sort of difficulty with having compliance with a medical procedure. Only 27% of individuals with ID or autism are fully cooperative with blood tests and injections. And this is related to fear and anxiety. Some of that is developmentally appropriate, but also related to previous medical trauma. And unfortunately, individuals with disabilities have oftentimes experienced medical trauma because of a couple of different reasons. One is that, something needs to happen and they're afraid and they've had to be held down in the past. And guess what? That's just not traumatic for the individual or the child. It's also traumatic for their caregivers who are watching this happen. And oftentimes when people come in to see me, they'll tell me stories about being held down in the past or having to have 10 people hold them down, and then they destroyed the whole office and we weren't able to get anything done. So the parents have a very real response, post-traumatic response to the idea of getting lab work done. And we find that people, even though there might be this attitudinal problem in thinking that individuals with disabilities don't have post-traumatic stress, we actually find that individuals have the same, actually, same if not higher rates of post-traumatic stress than the neurotypical sample, but also show it in many of the same ways. So, they may be having behavioral problems. They might have physical health problems, stomach upset. They might be having exaggerated startle response, not sleeping real well. All of these things, when we're thinking about triggers with healthcare access and the responses to them, are related to unwittingly medical trauma. So a couple studies done looking at, kind of what increases cooperativity difficulties. The higher the level of intellectual disability, the higher the level of poor cooperativity. Previous unpleasant healthcare experience, that medical trauma is part of it. Not having good preparation for the visit or the procedure, not knowing what's going to happen. Having a combative demeanor. And then also when parents are very anxious, that actually makes it a little bit harder. And we kind of talk about co-regulation when we're talking about, families and kind of working with, really difficult emotional situations. And even though sometimes people will say, our individuals don't read social cues very well, or, struggle with understanding facial expressions, I find that they're actually very exquisitely attuned with kind of the emotional tenor, especially of their caregivers. So when mom or dad are really upset, the individual is very upset too. So sometimes it's almost like, kind of bobbing in an ocean. Mom and dad's upset, the individual's upset, and the only way we can calm it is first we have to try to calm down mom and dad, and then the individual can calm as well. So, understanding the trauma that a parent has experienced is also going to be very important. And for those who are parents, kind of addressing that trauma, giving it a name and saying what it is, and then being able to find ways of trying to control the emotional response that you're having is going to be helpful as well. I have mentioned medical trauma a couple of times. It is a set of psychological or physiological responses to medical procedures that have been frightening. We do, one of the barriers I talked about was that there's not enough training for medical professionals or other professionals in working with people with disabilities. We actually have a HRSA grant here at Rowan and at the RISN Center, where we are able to bring in medical students and residents and PA students to really learn about working with people with disabilities. And we also have our own like snack stand or lunch stand that's that we have the ACT program come in, so that we're not just seeing people as patients, but we're seeing people working and thriving in their community as well. So having the opportunity to teach others about medical trauma is important. So I always include a resource on medical trauma for our medical students who also are learning about, how to gain access for medical problems. Okay, sorry, I skipped one. Um, it's also very important that we realize that behavior is a form of communication, especially when we're talking about trauma. It's rather than looking at somebody who might be having challenging behavior related to a medical procedure, we have to be thinking not, oh, they're being difficult, or they're not being cooperative. And I kind of hate that poor cooperativity slide for that reason, because what they're trying to tell us is that they're communicating their distress related to this. And we need to be thinking what has happened to them in the past, rather than kind of going in with the attitudinal issues of, they're just being difficult. So for people with autism or IDD, fear can look like noncompliance. It can look like combative behavior or aggression. It can look like hiding underneath the table or trying to get out of the room, trying to push your way out of the room. It can look like a meltdown. It's that whole sympathetic nervous system response of fight, flight, or freeze. So understanding that behavior is telling us something about what is challenging to the individual is important for us to keep in mind. And sometimes our individuals can't tell us with words. So this is absolutely where we need to be kind of a behavioral detective and figure out what it is that is making it challenging and then address that for them. In terms of noncompliance with needles, needle phobia is a very common occurrence just in the general population. About 3.5 to 10% of the population have a full-on needle phobia. A fear of needles is a much higher amount and is a diagnosable simple phobia, and are really a barrier to immunization and to getting blood work done. And about a half of children with autism meet criteria for at least one anxiety disorder. And their prevalence of anxiety disorders is really high. So when you start off with even one anxiety disorder, it's very common to have multiple types of anxiety disorders or difficulty with anxiety that then kind of all contribute to this difficulty. And many of them don't understand what the purpose of the procedure is. Why are we even doing this? With needle fear, there's also some physiological responses to this. They might have hypoxemia, low oxygen in the blood, which can lead to tachycardia and higher heart rate. They might have a vasovagal reaction, pass out, changes in hormonal levels. More importantly is higher levels of perceived pain. So because of this higher level of arousal and because of their fear and their anxiety, their perception of pain is actually higher. And then this leads to the avoidance of procedures that require needles. So we have to be able to address not only their anxiety, but also sensory integration difficulty and the previous trauma. So when we think about improving medical access, there are a couple of things I try to think about. The first is patient education and preparation. I mentioned before how I find out about medical procedures. Many times individuals don't know what's going to happen. And if you don't know what's coming next, and think about like all the times we use visual schedules and we use social stories and we say, first, this is going to happen, then this is going to happen. All of that helps with predictability, and predictability decreases anxiety. So if they don't know what's going to happen, they're not going to be ready and they're not going to be able to control their reaction to what's going to be coming on. We then utilize desensitization, and I'll tell you a little bit about that, giving people a sense of control, including start and stop signals. And this, I feel like, is very important and something we really talk to our medical students about, is that does this procedure need to be done today? And if somebody is telling you either with their words or with a signal or their behavior that you need to stop and they're not ready for it, you need to listen to them and give them that opportunity, especially for individuals with autism who may have gone through ABA therapy. We have kind of taught individuals to kind of go with the flow and rewarded them for going along with authority figures. Our individuals are at a higher risk of abuse than anyway, 10 times higher risk of abuse than in other individuals. And part of that is because we haven't necessarily given them the words or the power to be able to say no. And being able to say no to your doctor and having them respect that and then coming back and trying again is really important. We treat anxiety and previous trauma. We try to avoid incurring additional medical trauma, address their sensory issues, and work on provider patients. Like I said, not everything's an emergency. And sometimes we can say, if you're in the hospital, you don't need to have your blood pressure taken by the automatic blood pressure cuff all night long. Maybe we can do it just with an alternative procedure like a manual blood pressure cuff once a day, something along those lines. So kind of breaking this down individual within each individual area, education and preparation, utilizing social stories. I have this great video, especially when we're talking about lab draw, that is about 1.5 minutes that I can show that shows each step of the procedure that's going to happen so that the individual knows what to expect. Oftentimes we demonstrate on a family member, on practice on other people, utilize stuffed animals. So if somebody was coming into my office with a needle phobia or, some challenging behavior around getting lab draws done, I would do an evaluation first to see, are they even able to show me their arms? That's usually the first step. I kind of break down the whole process into individual components. So the first step would be, hey, can you show me your arm? If they can't show me their arm right away, I'll say, yeah, let me see if mom can show me her arm. And then mom shows me her arm, I touch and say, okay, now can you show me your arm? Most of the time I can get to that point. And then I have them show me both arms and then I take a step back and then come out with the tourniquet, right? So I say, oh, I've got something stretchy here. Is it okay if I put this around your arm? It's not going to hurt, but it's going to squeeze a little bit. Sometimes they say yes, sometimes they say no. If they say no, I ask to do it on somebody in the room and then see if they can do that. Sometimes that's as far as I'm going to get in the first appointment. And then we develop a program to take it home and then practice at home before they come in for the next appointment. So part of it is, just kind of an education and understanding in the way the person's able to understand it. Now, I do have to say, I've got many individuals who do not use words to communicate, and I often find that they understand more. They have much better receptive language than they have expressive language, and they will watch the video. And get from the video what's going on, even if they don't look like they're paying attention to the video. So, sometimes parents will be like, hey, watch this video she's showing you. I'm like, oh, they're okay. I know they're picking it up. And then I give the parents the video that they can practice at home as well. When we talk about desensitization, it is a very gradual exposure. So desensitization is a psychological term where we kind of create a hierarchy of stages of things that are less anxiety provoking to more anxiety provoking. And it doesn't mean that we're going to just flood the person with the scary situation. That's why we don't, like looking at this cartoon, we're not going to have you confront your fear of heights, snakes, and the dark all at once, because guess what? That's going to make people really have an emotional response, a sympathetic nervous system response, a fight or flight or freeze. So we're not going to be doing that. What we're going to be doing is more of a gradual exposure. And then looking either how an individual responds verbally or how their behavior or avoidance of the situation kind of tells us what the next step is. So this is just an example of a graduated exposure to a blood draw. I tend to kind of work around, what the individual can do and how comfortable they are. So sometimes, I've talked about showing me your arm, talked about wearing this around your arm, and then we might take out the alcohol swab. For some individuals, it's cold and they're not quite ready for that, or the smell can be challenging for them. So sometimes we have to practice a little bit with cleaning the arm. Sometimes then we have to go to the next step of just being able to sit still. So a homework assignment might be, take this home and we've got a video that lasts for a minute. We're going to gradually work up to a minute of sitting still with your arm while watching the video. And then when you've gotten that, come back and see me, and then we're going to do the next steps. So desensitization is a very gradual exposure to these things. Oftentimes on the first visit, we have an integrated LabCorp within our office. So sometimes we'll just go and see if the individual can even look into the lab. Sometimes it's like, nope, I can't even look into that. I'm going to keep going. Some individuals are interested. They'll want to look around. Some will actually sit in the chair. All of those exposures tell me a little bit about where the individual is and where we need to get to. Giving people a sense of control is important. And as much as I can possibly help somebody have a sense of control, that's what creates a feeling of competence. That's what helps us feel confident about things. When we feel like nothing is within our control, and let's face it, for a lot of people, they don't have a lot of control in their life. So giving them an opportunity to have control is important. So part of what comes out of desensitization for a lab draw, for example, is a personalized plan that is written up at the end that is available for the individual, for their support people, for the phlebotomist, and for the physician on exactly what is going to be helpful for them. So that might be timing. Would you like me to put the tourniquet on first, or would you like me to wash your arm first? Giving them a choice. I've had individuals choose. I had one individual choose. He did not use words to communicate. And he very clearly, with his gestures, told me he wanted to have the blood taken out of the front of his hand because that was familiar to him from when he had been in the hospital. So we created a whole plan and a social story of him getting blood out of his hand. Coming up with ways of distracting yourself, comfort objects or individuals that you would like to have in the room with you. Having some pain control, and I'll talk a little bit more about that, as well as the start and stop signals, and then caregivers as teachers and practicing at home. There's a procedure that we teach our medical students called tell, show, and do. And it's really kind of the 3 steps of any interaction with somebody who may be showing you through their behavior they're not ready for something. First is we always tell the individual what is going to happen and ask permission if it's going to be okay, right? So if we are going to look in somebody's ear, we would say, hey, I want to look in your ear. This is the otoscope. This is what I'm going to look in your ear with. Would you like to look at it? And oftentimes individuals will want to take a look at it. Is it okay if I look in your ear, asking permission? If they tell you with their behavior or their words that they are not ready, you take a step back, take a break, count to 3. And I usually say, you know what, I'm going to give you a couple of seconds. I'm going to step back here. Why don't you let me know when you're ready? And giving them that sense of control, oftentimes people are going to be much more cooperative and ready for something. Sometimes we're just kind of coming in at them too fast and not taking the time to develop rapport, and they're not quite ready. And then give them their start and stop signals. A little bit about distraction. Remember I talked to you earlier about perceived pain that is increased when people are afraid of needles. They've actually done some research to look at having distraction and the impact on pain. And they found that actually active versus passive distraction is better for perceived pain. So what is active distraction? Active distraction is actually doing something where the person participates rather than just looking at something, though we will utilize both. But it's sometimes what I do is I play I Spy with somebody while they're getting their lab work done. So, I spy with my little eyes something that is blue. Can you help me find something blue? Sometimes we work on just blowing bubbles or pinwheels. I teach anxiety reduction techniques like deep breathing to help not only calm somebody's body, but the part of the brain that is excited when we're anxious, so that once we are a little bit more calm, we can utilize our reasoning skills in the frontal lobes. These cards are actually like little games that we can play. Sometimes listening to music, telling a story. A lot of people will talk about, something that's coming up that's exciting for them. I have one patient who, every time she gets labs done, and because she has a vagovasal reaction, we have her lay down when she's getting labs done in a bed rather than sitting up because she had passed out before. But she likes to watch It's a Small World, the ride, and watch the whole video. And she watches the video while we talk to her about her next Disney trip. And that's kind of what gets her through it. We've brought pets in as well. Pain relief, a little bit about pain relief. We utilize pain relief within our practice through a couple of different ways. This is the Buzzy Bee, and what the Buzzy Bee, it works on this theory of pain called the gate control theory. And what it does is it vibrates at a certain frequency that signals the pain receptors within the neurons within your arm to not feel the pain. So and they also have like these little wings on the back that are an ice pack. So I give people the choice. Some people choose that they want to use the Buzzy Bee. Some want the wings, some don't want the wings. Some individuals just like the sensory input and they like to hold it in their hand. But the perceived pain by utilizing the Buzzy Bee really decreased. Over time, it decreased their perceived pain between 56 and 88%, and also decreased their anxiety about the procedure. So we utilize that. We also utilize something called a shot blocker. That's that little yellow thing. That tends to work, I think, even better for injections or vaccination. So it works on the same theory. It's got those little bumps, and what you do is you put it on somebody's arm, and in the spot there's the U shape, that's where you would put the injection in, and those little bumps actually kind of confuse your arm to feel where the injection's going in. We also use EMLA lidocaine cream. That has to be put on about 20 minutes beforehand to really numb the area. We've used a little bit of a vapocoolant before in the past too. So having individuals know that there's something that we can utilize for pain control is important for them. We work on anticipatory anxiety by telling social stories and explaining what's going to happen, that kind of worrying about what's going to happen. And having a plan helps decrease the worry. We practice deep breathing exercises, as I mentioned before, smelling roses, blowing out candles. One of the best ways, oftentimes our jaws get really tense when we're afraid of something. One way to kind of relax your jaw, which relaxes your whole body, is to move your tongue from the roof of your mouth and down. It kind of releases the jaw and helps you immediately feel relaxed. We teach some muscle relaxation, especially to be sure that the arms and the shoulders are relaxed. And I do that also in PAP camp. And some of our individuals will also get some anxiety relief from a medication that can help, a benzodiazepine. Sometimes they get a low dose of Ativan before they come in to help decrease anxiety. Our goal, we do know that, some individuals do need to have sedation, but we've found that we've been able to decrease like the full-on sedation with just a little bit of a benzodiazepine to kind of help decrease the anxiety a little bit, and individuals are then able, with all of the things that we're doing, to come in and get their labs done. And then also we want to make sure that we have some sort of reinforcement. So, knowing what's going to happen when you are proud of yourself after you get your labs done. We're going to go out to eat, we're going to go do a preferred activity, something like that. Lots and lots of praise. Coping with sensory issues is important as well. We do have a sensory room at the RISN Center, and we also helped create a sensory room during COVID to help with the COVID vaccines. So there are some individuals who want to utilize the sensory room, and they go into the sensory room to have their labs done. I'm going to skip over that and talk a little bit about a plan. So we put together then a care plan that addresses all of these things: fear, pain, sensory difficulties, behavioral challenges, and come up with a full plan that is about self-advocacy to get the care in the way that you need to get the care. So this can look like a lot of different things. For one individual, it was having their lab drawn in the beanbag chair in the sensory room with a weighted blanket, having mom there holding their hand and watching Thomas the Tank Engine, and taking some deep breaths. All of those things together led to a very successful lab draw. But it can be anything, and we are very I think we're really good at kind of pivoting and finding what the explicit thing is that's going to help. We also utilize an EMR system that allows us to communicate with anyone within the Virtua system. So if we find something that works really well for our patient, we can put that care plan in a flag so that when they go to other providers within Virtua, they can see what worked in our office. So we have good communication that way. And then there are a lot of family resources. I did say that we could share my slides. So these are all family resources that you can utilize. There are support stories. There's the video that I talked about, some calming strategies, all of these things that we can do. And then I mentioned, remember, there are alternative ways of getting things done. So sometimes it might mean, if we're not talking about lab draw, but we're talking about getting your blood pressure, sometimes it means doing a manual blood pressure. If you see the little EKG, so for some individuals, sitting still and definitely the sensory impact of all of the stickies for an EKG is really tough. So we utilize a CardioMobile, which only takes 2 fingers and then a third spot either on your knee or your ankle, and you only have to sit there for 30 seconds. So we can do a behavior plan and a desensitization to be able to hold your fingers still for 30 seconds. That's usually a lot easier in order to be able to get an EKG. And we're particularly looking at QTC intervals, especially for some of the behavioral health medications that individuals are on. We need to be able to get that done. I do a little bit of dental desensitization, but there's this brush and bite kit that's on there that you can purchase that is like dental tools that you can practice with at home as well. Now I want to talk to you for a couple of minutes about PAP Camp. So PAP Camp is another program that we have. So we were very, very fortunate to receive actually 3 different grants to be able to work on accessing routine reproductive health care exams, because there's a lot of, I guess, attitudinal barriers around getting a pelvic exam, including with physicians. So we've had patients tell us that their gynecologist have told them that they don't need to have a PAP exam because, they're not sexually active, which is not a prerequisite for having a PAP exam. So we've done a lot of work around, first of all, creating accessible information for individuals who have a cervix, and understanding that everybody with a cervix needs to have a reproductive health care exam at some point after the age of 21. We've created a lot of educational experiences for physicians about creating an inclusive office, about how to talk to individuals with disabilities, about alternate ways of laying, especially for some of our individuals with cerebral palsies. That type of difficulty with either shaking or with, spasticity, laying in the typical reclined position for a PAP exam is very uncomfortable. So giving not only the individual the knowledge that they can choose a different way of laying, and for the healthcare provider to understand that as well. So we've been able to create all of these things. And one of the things that we were able to do is put together PAP Camp. And PAP Camp is an experiential opportunity which will individuals learn what's going to happen during the exam, what the knowledge gaps are in terms of who needs an exam or doesn't need an exam, decrease the stigma about getting it done. And I think a lot of times, caregivers are a little afraid about PAP exams because it feels so intrusive. We have taught our individuals that nobody should be touching their private areas, and so it feels very uncomfortable to talk about that. And we want to be able to create a personalized plan for them to have PAP, or to have their PAP exam done. So I run PAP Camp here at the RISN Center. It's usually a one-time visit where the individual comes in. We talk about what happens during the exam. I actually have, I'm going to pull it out of my office. We were able to find these really good models. That are very concrete so that our individuals can really see what's going to happen, because it's a really abstract idea of what's going to happen and why it needs to be done. But this model is actually so good that I can show not only the model and a speculum and the brush that we are going to use, but the individual can actually perform a PAP exam on this model as well. And I've had individuals who don't want to touch it at all, and I always ask for permission before I bring it out, because sometimes, they can feel a little uncomfortable about looking at it. And then usually they're very, very curious. But I actually had one individual who, definitely wanted to do a PAP exam on the model, and I gave her the speculum, and she's like, wait, we got to stop. And I'm like, okay, what's going on? She's like, I need gloves. And I'm like, oh, yes, you do need gloves. So we review why it's important to have a women's healthcare exam, that everybody has them. If there are other women in the room, we talk about their experiences. And generally what I get is, my gosh, why didn't we have PAP Camp for everybody? Because PAP Camp kind of addresses all of your fears, and you know what's going to happen, and you walk out with a full plan that tells your provider, helps you self-advocate for what you need. So we go and we take a visit to the exam room. If they want to, they can sit down and try the footrests or stirrups. We have the models, and we'll talk about what happens during the breast exam as well as the pelvic exam. And then we talk about ways in which to help the individual prepare for the exam and what they would like to see happen. So we review ways to calm your body. And that includes some deep breathing. And we make it fun. They actually get, I don't have one here. I gave it away yesterday. We have little PAP Camp activity kits. So you get a PAP Camp flip book that has all of the information that we talk about. It includes bubbles, because we practice taking deep breaths in like we're smelling flowers, and then blow bubbles nice and slowly out our mouth to calm down. It includes a squeeze ball. It's actually a little brain, so they can practice. We practice progressive muscle relaxation, including relaxing your legs, because that tends to be the spot that gets the most tight, when somebody is anxious. We talk about ways of calming your mind. So we talk about distraction. We talk about videos they might like to watch. There's a QR code with some calming music. And then they come up with kind of what they want to have happen. We talk about positive thoughts. So if you have a thought, I'm really afraid about getting this exam done, you might say, I can do this. I'm doing something good for my health. We talk about support, if they want somebody to be in the room with them or not, and people get to choose what they want to have happen. And then we talk about their sensory needs and how we can accommodate them, and then write up a plan of care. So this plan of care becomes their advocate kind of step point. It's included within our EMR system so that everybody can view what's going to happen. We put in their stop signal, and then they write down what they want to bring to the exam, ways that they're going to calm their body, calm their mind, how they can get support when they're there. And I'll give you an example of somebody who and their plan of care for PAP camp. So it was a woman with cerebral palsy who does not use words to communicate. The way that she communicates is she wears a headband with a pointer, and then her staff, she lives in a group home, her staff come and they have the alphabet and then yes or no, a couple of individual words, and then she taps out what she wants to say. She had had a previous difficult experience with having a PAP exam. It was uncomfortable, it was painful for her. And she was really afraid of having another one. So this is an example of medical trauma. So what we ended up, after we talked through everything, we ended up discussing having a side laying position with one knee forward, and that's often used for individuals with cerebral palsy. So the exam then comes in from behind. She wanted to do that. Her body shook a lot, so she asked to have a weighted blanket. So she had a weighted blanket over her. She asked for her staff to be there with her. When we talked about a stop signal, she said she wanted to shake her foot because she didn't use words to communicate. And actually, because her foot shook a little bit all the time, she asked for us to put a bell on her toe so she could really ring it if she needed to tell the doctor to take a break, that she wasn't ready yet. She asked for the lights to be turned down and her hearing aids taken out because of sensory challenges, and for her support people to be there and to hold her hand. And with doing all of those things, she had a very successful PAP exam. So it's giving people the opportunity to have control. It's educating our providers that you need to listen to what works for the individual and what doesn't work. And let's be a little bit flexible on how we're going to accommodate them. It's giving them a stop signal to say, I'm not quite ready yet. And if somebody during a PAP says, stop, I'm not quite ready, we don't do it, right? We'll reschedule on a different day. Some people will go as far as to tell me, it's okay for the doctor to look externally, but I'm not ready for the speculum exam. I'm okay for the breast exam, not the speculum exam. But knowing what's going to happen, and we do have a video, the ARC of New Jersey shared with us a video that they had hired a self-advocate actress who was open to allowing herself to be videoed while she was having her exam. So because some of our individuals need to see it concretely what's going to happen. And we do provide that if somebody is interested in that as well. So with that, I want to give you guys an opportunity for questions. We have a few minutes. Perfect.
Thank you so much, Dr. Ada. That was perfect timing. We do have some questions coming in. First, I do want to recognize that the RISN Center is taking a strong focus in gynecological health, and I think that is a topic that is not often spoken about enough. I know that when your team and the CLEP team started initially talking about this medical series, that was one of the things that we sort of had to focus on, is that preventative health care and how those conversations don't often enough happen within this community. And gynecology is one of those conversations. So thank you so much for highlighting that in your presentation today. I think that that's really important for the attendees to hear some of that work that's being done to advance. One of the questions that was sent to me directly is at-home blood draw appointments. So if someone has such anxiety that they can't even get to the doctor's office, but that person does need a blood draw to happen, is an at-home blood draw an option? And do you know anything about that?
Yes, absolutely. Thank you for mentioning that, because sometimes that is the plan. Sometimes the plan is that coming here is very, very anxiety provoking, but being able to have a blood draw at home. So we do write orders for at-home blood draws, and a company will come out to your home and schedule the at-home blood draw. I think one of the biggest challenges for families when we have sent for those is sometimes they don't know when they're going to come. They'll just tell you they're going to be there in a certain day. And if it's a lab draw where you have to be fasting, sometimes you can be waiting a long time. I always recommend that the individual or the family talk to the doctor and find out whether it really needs to be fasting or not. Because sometimes it's always thought, oh, it needs to be fasting, but there are some that it doesn't matter if they're fasting, or as long as the doctor knows that they weren't fasting, that's okay. But yeah, we absolutely send out for at home blood draws.
And I know that we've had that for my son many years ago. One of the things that we found beneficial is to call that whatever agency is going to be coming out, explain that situation, make sure that they're scheduling a date where you could be that first appointment on,
Yes.
so that that fasting isn't such a challenge for that
Yes.
individual, right? We're not looking to cause more anxiety for someone. So I think that's a great option for a lot of people if they require that kind of support. So.
Yeah,
Um,
absolutely.
we do have someone asking if the RISN Center has a wait list for new patients, and do you also provide dental care?
Oh, that is a question, right? So we don't provide, well, I'll answer the dental question first. We don't provide dental care here. However, we do have relationships with a number of dentists that we utilize, and we have found one in particular, Special Smiles, has been really good at getting our patients in without a very long wait list, because that, that barrier of needing sedation can sometimes put people off for a couple of years. And guess what? Behavioral challenges are sometimes related to dental pain. And, those of us in behavioral health can't be working in our own little silo thinking, oh, this is psychiatry, we need to throw more medication at it. Oftentimes, a change in behavior or behavioral challenges is due to dental pain, very, very often, actually. So we utilize Special Smiles. We have also worked with some dentists if somebody needs sedation to try to coordinate all of access under sedation. So if they're getting sedated for dental care, we try to get labs done at the same time, get their ears checked. We've even been able to coordinate with OBGYN to go in and do a PAP under sedation when necessary. So we do that. RISN Center does not have a very long waiting list, so I'll put it out that way. We are still accepting new patients. It really just depends on how quickly we can get somebody in for their first appointment, a new patient appointment. So I think at this point we are out into maybe July, so it's not too bad where we are now. But if you're interested, give us a call. Just some caveats: we accept patients over the age of 18, so we don't see children. Um, we are looking for individuals who live close to where our offices are. So we have an office in Gloucester County in Sewell, and we're opening a second office in Vineland in July, so down in Cumberland County. But sometimes individuals will say, well, we want to come to RISN Center, but we live in Bergen County. And the reality is we want to be your medical home. So we want you to come for everything, right? When you have an ear infection, when you need a checkup. And sometimes what happens is if somebody lives too far away, they end up going to urgent care a lot rather than coming down to our office just because of the distance. So that is, sometimes one of the prohibitive factors. And sometimes we'll say, I'm sorry, you live a little bit too far away for our office. We'd like to be everywhere in the state, but right now we're just in these two counties.
And we would like you to be everywhere in the state. So Dr. Ada, can you, that person is asking if you could repeat that dental practice that you just mentioned?
It's called Special Smiles. I think they're located in Cherry Hill, but they have an office in New Jersey. But when they do the sedation, it's in their Philadelphia office. But they do take the Medicaid. They take New Jersey Medicaid. So you are able to utilize your insurance.
One of the resources that we've used and in the past is social media, for example, Facebook, right? There's a lot of New Jersey specific disability sites on Facebook. Find those sites, sign on and ask those other families, right, for those referrals. Who do you use and who has been successful for your loved one with these needs? If Cherry Hill isn't in your area, you can always feel free to reach out to the CLEP team. We can share just through some of our lived experiences, some of the positive practices that we've encountered, to see if that might be a good resource for you in your area also. I do see that we have a question in the Q&A section. Let's see. You're receiving a ton of compliments or come through. I also see it says, my apologies. My apologies for I may have misunderstood something earlier. Would you please clarify or re-explain how to handle a medical visit that has gone awry? For example, patient outburst because caregiver asked a question, loss of independence. Can we ask medical providers to leave and come back a few minutes later, or is it necessary to schedule another visit? And then what if they say no? And what if the visit is more emergent?
Mhm. Yeah, so I think you've got a lot of different things going on, and definitely individual preferences, unfortunately, and how comfortable you are to talk to a medical provider and how receptive the medical provider is in receiving it. So when it is an emergent situation, I think you always have to put the individual safety and health above everything. And unfortunately, that's some of the times when there might be some medical trauma because there is an emergency. We need to get something done. We need to get x-rays done. And, going into the x-ray, going in for an x-ray is difficult or something like that. What we do here at the RISN Center, even before you come in for your first appointment, is we ask questions about what things the individual likes to talk about. What are some distraction items? Should we wear the white coat or not wear the white coat? Is the first appointment of the day the best? So you don't have to wait in the waiting room, or is the individual not wake up until later? And that would be really difficult and you want to make it a little bit later. Those are things that you can think about in terms of what would make the experience better for your individual and request those things. So sometimes in the moment, you might not be able to get all of the accommodations that you need. But the goal is for people to be able to get access to healthcare in the way that they need it in a timely manner. So I would not consider asking for basic accommodations, and time is a basic accommodation. Asking for more time. You're going to need a longer appointment. You're going to need to come back, and it needs to be in the morning so that we can have a better experience. All of those things you can advocate for, and I, would encourage you to advocate for those things.
Absolutely. And please, I think I look at my son who is going to be 27 now, and I look back at his younger years and I think, wow, like those little steps in success have really equaled, right? A more positive and successful medical experience over those years. So again, little by little, right? Little steps and sharing what is going to work for that individual. I know that, we've in the past have even sent emails prior to our visits sharing, hey, these are some of the best practices, things to talk about, things not to talk about. And that all really adds to a more positive experience over time. So,
and it teaches the healthcare provider, and they want your loved one to have a good experience. So they want it to go well also. So, don't, and what's nice is we now have my chart, right? So you can even send a little message through my chart and somebody will read it and, hopefully make those accommodations for you too.
absolutely. So I do see that people are sharing some resources in the chat. That's exactly what we want you to do. I do see someone is asking about the PAP camp. How would they go about exploring that further? Can they reach out to you?
Yeah, so currently we are not doing PAP camp for patients who are not our patients, unfortunately. So it is just for the patients who come to RISN Center for Primary Care, partially because some of what we're doing is setting that individual up for the experience within our office. Our primary care doctors will do the gynecological exam, so we don't have to send them somewhere else. Our goal is to, at some point, be able to extend this and be able to offer PAP Camp as its own separate thing, but we haven't quite gotten there yet to be able to do that.
Well, thank you for going in that direction. We greatly appreciate it. I see that we are past one. I want to be conscious of your time. I'm sure you have upcoming appointments. You will see that on your screen. We currently have a QR code. You're also going to get this link as we're preparing to say goodbye today. It's going to be the information that you provide that, will allow information to be shared in a wider way. And we have more of a focus of what the community needs will be in the future. With that being said, I do want to thank you, Dr. Ada, for your time, your dedication to this community, and your expertise and resources that you were able to share with us today. I would like to take just a quick minute as we're preparing to say goodbye on behalf of the CLEP team. It is with deep regret that we announce that after 33 years of dedicated service supporting people with disabilities and their families and exploring the various options of community living, that CLEP is anticipating loss of funding come June 30th. We have recently been notified. The CLEP team would like to take this opportunity to really thank you for joining our information sessions over the years, and we are really wishing all of you the best moving forward. Please continue to advocate, continue to learn, and really please inspire others to make positive changes for our community and for the people that we love and we support. So please be well, everyone. Thank you again for joining us. And Dr. Ada, we thank you so much for joining us today. And please thank everyone at the RISN Center for their ongoing commitment to the disability community. So thank you so much.
And thank you for all that the CLEP has done for all of these years. It is with great sadness that I hear about the loss of funding, and I'm, very sorry to hear about that. You guys have done wonderful, wonderful work, and
We have a
hopefully
great team. We'll be back.
we can come back.
That's it. Hopefully we'll continue, right? We're
Yes.
hoping, we're really hoping to be able to continue, find a way for that to happen. So thank you so much. Please give everyone our best. We wish you all well, and thank you for joining us.
Thank you. Bye-bye.
Thank you.